All right, guys, let's do a couple minutes more. Hopefully we'll get out a little early today. No exact promises. Okay, so some final topics. And a lot of this stuff isn't testable, so you can kind of sit back and relax for most of it. I will ask you one actually short answer question on this exam. So mixing it up a little bit. I'll explain that here in a second. It should be 3 points on this coming test. Yeah. Yes, I said exam. Yeah. There'll be a short answer question on this exam, and I'll explain that when we get to that section here. And again, it's basically 3 points if you try. So I just want to talk about some medication safety things and how we prevent medication errors from happening. I know not the most interesting stuff, but I think it's really important. So there's a couple different resources out there in case you're looking for things. So if you want to know, if your patient comes into your office and says, I need to crush these medications for my elderly relative or something, how do I know what to do? ISMP, something called Institute for Safe Medication Practices, and they have a number of resources like do not crush lists, abbreviation things such as like tall man lettering, which helps differentiate certain drugs that look like, sound alike. Black box warnings, FDA alerts, they have some stuff like that. NIOSH is the National Institute for Occupational Safety and Health, which has guidelines about like exposure and things like that. Yes?
Sorry, we were being loud at first. You said this lecture is going to be on the exam.
There is some of it that's going to be on the exam.
Okay.
I'll point out exactly what will be there.
Okay.
Yes, the safety stuff, no.
Okay.
So this is another question I get a lot from providers, patients. Everyone seems to wonder about this. How do I dispose of medications? Go to hennepin.us/medicine, and it tells you a lot of different information. But basically, there's a lot of different drop boxes at sites throughout Hennepin County. A lot of them are at police stations, but some of them are at other places, and they look like this. Oh wait, that's not. I don't have a picture of one. Oh well. They're basically like a big green. They look like kind of a big green mailbox, and you just literally put your medications in it. You don't have to do anything. You don't have to record what you're doing. No one's watching. Well, I assume there's a video camera on there, so no one steals it. But you can put controlled substances in there and all that type of stuff. So that's why they're often at police stations, because of the legal restrictions around returning controlled substances. Otherwise, this is the basics on what you don't want to put like sharps in there or something like that. That's a different way. You should have a sharps container or something designed to hold that. And again, no ID required. It's free. And here are the different locations of that. So, very easy. I always refer patients to here. I think it's probably the best way to get them disposed of properly. Hospitals can dispose of medications as well. The thing is, we pay a lot for that service. So if somebody's just coming in off the street with a garbage bag full of junk, I don't really want to pay my astronomical fees to get my waste handled appropriately when the Hennepin County system has something set up for those patients already. So don't tell your patients to bring it to the hospital. Some pharmacies might do stuff like this for their patient. They can always ask, but generally this is the way I would go. So certainly you don't have to do this all the time. Hopefully it'd be maybe like a once a year thing. Clean out your med cabinet, throw your stuff away.
And is it true that you shouldn't flush the water?
Yeah, so that's the other thing. That was a recommendation for a while, and sometimes people will still say to do that with C2s because it's the only way to assure they get disposed of. But yeah, it does get into the water system. So the way that's recommended, if you aren't going to do something like this, I believe, by the way, these locations, they eventually incinerate the medications is how most places deal with them to make sure they aren't getting in. Now, is that contributing to emissions or whatever? Well, another discussion for another day. But yeah, not getting them into the water streams, water table, etc. is good to think about. The other way that you can do it from home is the recommendation is to kind of neutralize the meds. So dump them in. Some people say like mix them with something that no one would want to get at. So like motor oil, or like anyone has motor oil, like dirty motor oil is sitting around. I don't know, maybe people do. Or like kitty litter is another recommendation. But again, much easier just to go to the drop box than to go buy kitty litter, mix it up in a bag or a bottle that somebody can't get into, tape it shut, and then throw it in the trash where it's going to go sit in the landfill. I mean, this is the more environmentally responsible way, and it's the better way to get it actually out of the system. So certainly, yeah, if you're adulterating it with dirt or kitty litter or oil or whatever, no one's going to probably want to take it, but it's still something to think about. So basically, yeah, try not to flush them down the toilet. Try not to just throw meds in the trash. That's probably the end of the moral of the story here. Use your appropriate drop box sites. That would be my recommendation. I don't know. I think Ramsey has something similar that I looked up, but I haven't looked into that. Yeah, that's a good question, but I don't know. Okay, an adverse drug event. We've talked about tons of these. There's different definitions on there, but things that we can prevent are where we like to focus our medication safety efforts. So when it comes to certain adverse drug events, there's just nothing you can do. Right? If somebody never has a medication before and they take it and they have anaphylaxis, well, how would you have known that was going to happen? You have no idea. Some medications are more likely to cause anaphylaxis, and you can have medications to help treat it, but you still can't prevent anaphylaxis from happening. So stuff like that, or like if somebody takes an antidepressant and gets dry mouth, well, that's just part of the drug. I mean, it's not necessarily something we're going to do a whole lot about. The preventable adverse effects are things we want to handle. I'm not going to go through all the stats, but this slide basically says adverse drug events are a big problem. There's a lot of hospital admissions tied to them, and that equals a lot of dollars. So we spend a lot of money trying to correct adverse drug events. So if we can get those controlled on the community side, or at least prevent the damage they can cause on the patient care side and on the financial side, that'll help immensely. So again, hospitalized patients are a big risk category, either for getting an adverse drug event while they're in the hospital, or having an adverse drug event cause them to be hospitalized in the first place. It can occur in up to 30% of hospitalized patients, depending on what study you read. A lot of them don't do anything, which is great. About 1 in 1,000 statistically can cause long-term disability, and 3 out of 1,000 actually have been linked to death. So they aren't benign. It's rare to see something like that happen, but it does happen every once in a while. Financial burden, cost estimate, if you do like calculations on length of stay and stuff like that, which again is kind of funny money, $1,900 to $5,900 per adverse drug event that happens. So a lot of money spent on correcting mistakes. So how do we avoid adverse drug events? Well, computerized physician order entry. First of all, make sure that you're ordering your orders specifically. So you aren't putting them on paper and then somebody's transcribing them. You're actually putting them into the chart yourself. They go to a pharmacist, I review them, and I make sure that there's a number of safety parameters that are being met. So I'll get flags if there are drug interactions. I'll get flags if it's a renally adjusted med and the serum creatinine's high. There's a number of other ones that pop up too. Relevant labs and stuff will show up. But for the most part, make sure that you're actually entering your orders as you want them to be written, and then somebody else is reviewing that. And then also the nurse who's going to be administering it should be doing kind of a similar thing as they're doing the administration process. Bedside barcoding is the second thing that's linked to substantial reduction in adverse drug events, and that's actually scanning the medication and the patient at the bedside to make sure that it's the right thing. You wouldn't be so surprised how many times you get a phone call saying, "Hey, I'm scanning this drug, and it's not saying it's something I can administer." Well, what are you holding? Oh, it's not the right drug. Yeah, there you go. So maybe our machines got stocked incorrectly. Something might have gotten mixed up in the nurse's pocket. Maybe they gave a medication to another patient or had 2 of the same thing. You never know what happens. It's easy to mix stuff up. And that's why when you're actually administering the drug, you're supposed to scan, and that should lock it in, and then should give you the go-ahead that you've got the right drug. So it's a nice second check, I think. If I was a nurse giving meds, I think it'd just be nice to know that I've got a computer backing me up saying that, yep, this barcode matches that product that was ordered. Some common detection methods, yeah.
Is this always done?
No, so I think every major health system now in Minnesota has CPOE, but you might go other places in the country that don't. I've never worked in a hospital without physician order entry, for example. So I think Health East was the last system to go live on Epic. And they just did. Are you guys familiar with what Epic is? So Epic's like the major CPOE or EMR that pretty much every major health system uses. Cerner is one of their big competitors, but not even close. Epic's ginormous, and they're almost like a monopoly. Everybody uses them. Mayo actually just went live on Epic. So if Mayo's doing it, they have their own homegrown thing, and they think they're better than everybody. So anyway, they finally got on board with Epic, and I heard they spent like $1.5 billion implementing it. So not cheap. But definitely it does. I think the models do show that you save a lot of money on the back and years to come from the safety checks you can put into place. So no, not everyone has computer entry. Some places might have, especially if you go to like a small rural area that's not linked to a major health system. But even a lot of the rural hospitals now are affiliates of larger systems. So they actually buy Epic. Like we have affiliate hospitals that, well, they used to be. Now they've kind of become part of Allina. But before they became Allina, like for example, Buffalo hospitals, like 25 beds, they would actually buy Epic, they'd license Epic out of Alina. So Epic doesn't even deal with small hospitals. They say, no, you got to go to a bigger hospital and buy it from them. So it's kind of funny how it all works. But anyway, you might run into that where some place doesn't have it, but pretty much by far and away a lot of the places in Minnesota at least have it now, which is good. Now other states I can't speak. Epic's born in Madison, so I think a lot of Wisconsin hospitals should have it as well. Children's has Cerner. They're the only ones in the state that don't have Epic, in case you go do pediatrics there. It's very similar, though. Pretty much the same thing, just slightly rearranged. Okay, so besides these preventative things, how do we detect this? So this is really probably one of the biggest problems in healthcare is reporting, detection, and then figuring out what to do about an adverse drug event. So one of the biggest ways we actually detect these is by some system called a PVSR, Patient Visitor Safety Report. So if something happens, we rely on an employee to actually document that and fill that out. It goes to a system. So in my workflow, I monitor a lot of our distribution systems. So if something got stocked incorrectly and got administered to the wrong patient or whatever happened, it might come back to me and say, Chad, look at this and figure out why that happened, or where's the system failure? And I say, well, I can go back and see that the nurse took this out and didn't scan it, or maybe the technician stocked it incorrectly or whatever it might be. So that's how we review things. Obviously very manual and very retrospective. Sometimes I get these event reports and they're months after the actual thing happened. So it's like, well, at this point, how much impact am I going to make, especially if it's a one-off thing? But it's still important to look into these, and we do actually take them quite seriously. So my point in talking about this is if you have something that happens, it's on a system failure or just something that should have been caught, and it's going to be annoying to you and frustrating. It's frustrating for everybody when the systems fail and something gets through and we get possibility for patient harm. I'll give you the example. I had one of our docs come to me and talk to me about a patient who he prescribed it was an asthma allergic reaction. He prescribed a course of prednisone, like a prednisone burst, 7 days, and some Benadryl as needed and Pepsid. Well, she went to the pharmacy and for some reason she only filled Pepsid, not the other two drugs. We don't know why exactly. But then she came back into the ED the next day. She told the doctor she was taking the prednisone. She wasn't, because we could see in our records that our outpatient pharmacy never actually filled it. The doctor said, okay, just keep taking your prednisone. We'll see if it improves or not. And she came back in with worsening hives another day. So 2 more ED visits, all because she didn't fill her one medication. So we worked together. I worked with the doctor and we wrote up a report. We put both of our names on it and we kind of sent it through the system. It doesn't really have anything to do with my work, because I don't really know what happened with it. But it's an example of something that comes up, and definitely write that stuff up and don't be shy about reporting that. Even if it's minor, I still think it's worth doing. And certainly, if nothing else, it's a statistic. And we can say, okay, we're getting this many PVSRs about this specific incident. And maybe for you, it's the first time it's happened, but maybe at a hospital down the street in the same system, it's happened 4 times in the last month. And so it adds data to those different incidences. And if you're seeing a lot of the same thing, it can help on the system level trying to figure out what's going on. So again, I encourage you guys to take advantage. A lot of health systems have a reporting system like that. It's cumbersome. You have to manually type it in. It's annoying. I don't do it as much as I should, but it's definitely important. I'm not going to talk much about the other two. Chart review, you could look at the chart and say, oh, I see that this patient's creatinine increased suddenly. What caused that? That would be kind of like a chart review type thing. We try and do that every day on all of our inpatients for pharmacists who are working on specific units, but it's difficult to get to everything. And direct observation would be just seeing it. So you actually saw somebody have anaphylaxis or something like that. That would be a direct observation. Next step, so some of the technology you guys might see coming out would be a real-time trigger tool type thing. So let's say real-time is very difficult in medicine. So because a lot of things rely on labs, so let's talk about heparin-induced thrombocytopenia. So if we want to see a precipitous drop in platelets tied to heparin, we want to stop that heparin as soon as we know about that. Well, what if no one notices the person's platelet drops and they've been on heparin for 24 hours and like, oh, their platelets dropped last night and no one noticed? It's possible, unlikely, but possible. We have strategies in place. So lab, if they get really critical results, should be calling somebody. But also you can set up some of the computer systems, like Epic has a functionality like this that we don't have live yet, but I think it will be more prevalent soon, where it might message somebody directly. So let's say I'm a pharmacist working on our spine unit and that patient's on heparin, their platelets went down below 60. I'm going to get a message saying, check this person's platelets and make sure that everything's okay. So I can work as real time as possible, but ultimately you're still working in the past, right? Because that lab was drawn at what time? You don't know, a couple hours ago. And so you're still not actually in real time, which is going to be pretty much impossible until we get lab technology that tells us instantly what's going on. That's, I don't know, maybe in the future, we'll see if that ever happens. So my point is that it's challenging to find a system that works for all of this and to really identify these in an appropriate way, in a fast way. A lot of times we're working retrospectively and then trying to correct the system flaws, which is good, but still not perfect. All right, so I'm not going to talk a lot of, you guys will get very comfortable with EMRs over your rotations. I think it's very intuitive, most of them. They're kind of overwhelming at first. There's a lot of information. There's a lot of different ways to do things, but knowing how to quickly check labs, assess drug interactions, identify allergies, those are really important things from my perspective when you order medications to be able for you as a provider to have looked at. So I get a lot of questions. I get a lot of things ordered, and it's like, this patient has a documented allergy to this. Why didn't anyone look at that? Sometimes providers don't get the same level of alerts that we get. So for example, if somebody had an anaphylaxis to medication, that would probably come across your screen if you try and order the med. If they got GI upset or a rash, that might not. That might be a lower tier listed, so you might not actually see that. So sometimes you don't, but I think it's always important for you guys to double check those types of things as well. It just saves everyone a lot of time in the long run. So from a medication standpoint, I think those three are probably the biggest things to just think about when you're ordering meds, but use your EMR. You have all of it right in front of you. It's just a matter of figuring out where it is. Don't make extra work for people. Okay, yeah, don't make extra work for me. Duplicating orders and order sets. I can't tell you how many times I see this happen where like the PA and the MD didn't quite communicate greatly, and then I get 2 orders for Dilaudid on the same patient for the exact same dose. Well, I'm not stupid. I know that was a mistake, and I'll just DC one without talking to you. But ultimately, just, you know, especially with order sets or things like that, if you're talking to somebody about a treatment plan, finish your conversation by saying, okay, should I enter those orders? And a lot of times the doc will say, I'm going to go enter that to me, and I appreciate that. Or they'll say, could you enter that for me? And I'll say, yes, I can. So, you know, just making sure we're clear on who's entering the orders. It just makes everything easier. Don't leave it up to, so let's say you just had a 30-minute conversation with your pharmacist about a treatment plan, and you walk away thinking they're going to enter it, but I don't enter orders specifically unless somebody tells me to or it's an emergency, because I'm bypassing the security system that way, because then I'm checking myself. I'd rather have you enter it and then I can check it. That's the way it should be done. So unless you tell me to or I have a really good reason to, I'm not going to. So if you have a conversation with me, just assume that you're going to be entering it unless you specifically ask me to. Just a little bit of advice there when working with multiple people who can enter orders. Okay. Outpatient prescribing, I talked very briefly about some of this stuff. You guys have had some of this, I think, in the past, but e-prescribe if you can. Always use electronic prescribing processes. Narcotic electronic prescribing is getting a lot better too, so you really don't have to do handwritten prescriptions for almost anything anymore. Handwriting errors and problems are a big source of outpatient angst, so if you can e-prescribe, you're going to help them out a lot there. You may not have access to all the features of an EMR, so if you are doing e-prescribing, you might just want to do some more manual checking. If you don't have information about other medications or allergies, if you're kind of in an isolated system or doing like minute clinic type work, I don't know how comprehensive their systems can be. That would be something to actually ask the patient, okay, allergies, medications, those types of things, so that you know that ahead of time before you send the prescription over. I always say don't assume the pharmacy you send the prescription through will provide all the counseling points. There's really important things I think you should be counseling the patient. If they hear it twice, it's going to be better for everybody in the long run. So the pharmacist should legally be counseling the patient, but you don't know. If you really want them to know about one specific side effect or think that one aspect of the drug might really be effective for that patient, or there might be one side effect they're worried about, you just want to make sure that you get the most important information distilled to them. And the pharmacist might go through a more comprehensive list of things with them. Costs will come into play. Talked about insurance a lot, talked about prior authorizations. If you prescribe something that the insurance doesn't pay for, you'll get a call back about an alternative. So always think about that if you're prescribing a newer medication, to maybe have an alternative in the back of your head of what could you prescribe if this isn't covered by your insurance. Okay, transitions of care. So what are transitions? A transition of care is anytime a patient moves from one point in the healthcare system to another. So admitted or discharged from the hospital, hospital assisted living to home. These are places where things get lost and fall through the cracks. It's it's really actually quite disappointing. You have people who leave the hospital and you give them a perfect treatment plan, with all these medications on it that are changes, and you go through it all with them. They leave the hospital, they go home, and they have all these old meds in their medicine cabinet, and they forget, and they just start taking old stuff again and don't adjust it. Happens all the time. So how do you deal with some of this stuff? Well, some of it's social work, some of it's communication, some of it's getting more healthcare providers involved. There's a lot of different ways you can go about it. But transitions are really important to target and to address the fail-safes that are not being met with transitions. Because if somebody discharges from the hospital and they don't take the new medications they're on, or they take something that they had an adverse drug event to, or whatever it might be, they're right back in the hospital. Then you get dinged on that. That's bad for the patient care. It's bad for everybody's financial point of view. Usually you don't get paid for readmissions. The insurance company says, sorry, that's your fault. Your patient should have been taking that med. You should have educated them better. We aren't paying you for the second admission. Too bad. That actually happens quite a bit. So readmissions are a big deal. And that happens, that'll get back to you on your side. That gets to me on my side. So a lot of the investment we make as far as ancillary services has to do with this. So like, for example, when I started at Abbott, pharmacists were interviewing about 30% of people getting admitted through the emergency department to the hospital and completing their med list. We were just doing them kind of as we had time, which wasn't very often. Now we have added about, 7 or 8 staff people so that we do about 95 to 98% of all admits throughout the hospital. So surgical admits, direct admits, ED admits, we do them all. There's a few that slip through the cracks, but it's shown a big improvement on what's getting ordered on the inpatient side. So if the right drugs get ordered when somebody's in the hospital, you'd be surprised at how many, I'm going to throw surgeons under the bus here, but how many surgeons just order all the home meds and don't even look at it, don't even care if their H&P is correct. And I'll tell you that every H&P I get from a surgical office is always wrong. It's never right. So I sit in pre-op and do this sometimes, and it's really actually kind of scary that somebody would click on it and not really know. And what happens is you get all these medications that are dosed incorrectly, things the patient's not taking anymore. You're missing chronic meds that they are on. It's really problematic. So that's where we've basically given up on some of the outpatient side. We're not going to fix necessarily all the surgical practitioners out there that are putting in these wrong H&Ps. We have to do this differently. So we have pharmacists interview the people that go through all the meds. We use different secondary sources to see, like I can see in the computer system, a lot of the times every medication somebody's filled using their insurance transactions and also through different outpatient pharmacy data. So I can say, hey, I don't see this insulin pen or this Lantus pen on your med list. Are you taking Lantus? Oh yeah, I use Lantus 10 units a night or something. So it happens a lot. And so we use our electronic medical record to help us there, but it's also something that as pharmacy we sort of stepped up to and said we need to take this over because we do this the best. Tooting my own horn a little bit here, but anyway, the point is that if you target some of these transition points, you can really make a big difference on the patient's overall stay. There's a lot of good evidence that shows that if you do some of this, you're reducing length of stay, you're improving overall readmissions and things like that, which saves everybody money. It's better for patient care as well. Yeah. It is, yeah. MedRec's the common term. Med history is technically the appropriate thing.
Did you, before you go, you said the money, they won't refill it if you get ordered inpatient and they won't get it outpatient, is that right?
They won't refill it?
Yeah.
I think I was getting at reimbursement from insurance. So if you get discharged from a hospital and then you readmit within like 30 days, sometimes it's for whatever reason. It doesn't even matter what it is. So sometimes it's beyond your control. But you usually don't get reimbursed from the insurance for that hospital stay. So you're eating thousands of dollars as a system at that point. So that's why the transitions are important. That's what I was getting at there. As far as refilling stuff and getting meds, there's usually no problem with ordering stuff from home inpatient or prescribing it outpatient. That's pretty seamless most of the time. All right, so yeah, this is MedRec or med reconciliation. Technically, med reconciliation by definition is when you as a provider go in and order all the home meds. That's reconciling that list. What I do is do what's called a med history, where I actually talk to the patient and I go through their meds with them and I make sure that that list is correct. Ideally, I'm doing that before you guys would order anything. That's the best workflow, and that's why we started putting people in pre-op and surgery to talk to patients before they even go to talk to their nurse. So we're doing everything early, and then by the time you guys or your surgeon would order something, it's all correct at that point. So we're trying to get those errors corrected beforehand. Discharge counseling is something that we haven't done at our hospital. It's a huge time sink, and how we'd even, like sometimes we discharge 100 patients in a day. How would we even approach that? I mean, it might take an hour to do discharge counseling on a patient. So how on earth can we staff that? That's some of the stuff I think we'll be talking about, how we do that. Currently nurses do it, but I think definitely if there's important points, providers should be intervening on some of that too. I think, again, multiple people telling the person is important. I think our provider groups do a really excellent job of summarizing the discharge changes in their notes quite well. Whether that information always gets translated to the patient perfectly is another question. And then affordability of the medication. So I try and document in my notes when I'm doing my med history is this patient doesn't take their inhalers because they can't afford it. So redoing those things. I actually have a ability to flag that, so when you do a discharge summary, you will see that pop in and say, hey, the pharmacist reviewed this and said something about cost. You maybe review that with the patient, see if there's a better alternative for them. Another thing, if your patient's saying, oh, just send the prescriptions to my home pharmacy, I'll fill them there. Don't do it. Fill them at the hospital. Actually, 30 to 40%, depending on the study you read, of patients that are given prescriptions to go home and fill will never fill them or never pick them up. Whereas if you can fill them at your hospital and give them in hand a bag of meds, here you go, have fun, they obviously 100% will get them if you're doing everybody. So some patients will be really strict and some patients are fine. You can use your judgment on that. But if you're erring on the side of safety, I would recommend filling them at your discharge pharmacy in your hospital. Okay, I'm going to skip the MedRec stuff. This is the Abbott pilot in case you want our data of what we did. Basically, it took us 23 minutes per patient. We found that people really liked it. That's about it. Our MDs were very satisfied with our work, so there we go. We started our pilot with our ED-MDs and then also with our hospitalist group, and we kind of ran out of time in our pilot and where we were trying to expand services, and we didn't get more staff approval, but our ED physicians and providers, we didn't really have PAs at that time, so that's why I'm being selective with the same physicians. But our ED physicians and our hospitalist group were so adamant that they wanted pharmacist involvement in it that we actually got the money to hire more people for that. So anyway, pharmacists are very involved in this, but it is more or less everybody's job. It's always your responsibility, I think, if you're ordering home meds, to make sure that somebody did it. So at least looking and saying, okay, I see that Chad did the MedRec this morning. Great, I'm going to order those. Or no one's done this yet. Maybe I'll call the nurse and say, hey, has pharmacy tried to get in? Or can you do it? Or can you talk to the patient? Or do I need to come talk to the patient? Or maybe you talk to the patient and you're noticing that they told you stuff that's different than what's on their home list. I mean, it does happen where somebody tells one provider one thing and then they tell the pharmacist something totally different. Yeah, so you never really know exactly what's going on, but you can use some of those computer sources to figure that out. Institutions have different practices. Not all hospitals have 100% pharmacist medication reconciliation. However, that's becoming more or less standard of care. So don't be surprised if you see that pretty much everywhere. I talked about some of this stuff. We'll ignore that. So for the exam, I'm going to ask you a question that reads something like, I'm paraphrasing, but something like, in your future practice, so imagining where you want to practice, just how you would incorporate some best practice type things to make sure transitions of care go smoothly. So you could talk about medication list reconciliation. You could talk about making sure that your patients understand counseling tips. Anything like that would be appropriate. Just use your imagination and write a paragraph, and you'll probably get full points. I've never not given somebody 5 points, so go for it. Don't get too stressed out about it. All right. Tips. Okay, so in the clinic, so in your clinic, your patient should always have current detailed medication lists that you can keep with them, update them as needed. That's really important. You can have your nurses do this, certainly, but just make sure they're getting this done. If you make a change on the medication, please update the list for the patient's purposes and also in your computer system. Happens a lot where nothing gets updated in the computer system, and I go back and read a clinic note, and it's like, oh yeah, they changed the dose, but no one ever changed that in the actual computer system. In the hospital, again, we talked about some of this stuff, so I don't need to repeat that. And we talked about this as well. All right, MedRec, enough MedRec. Yeah, we don't need to go through that. Discharge, we already talked about discharge too. So I've spent a lot of time in my career on MedRec, so that's why I have a lot of slides there. But I think I gave you guys a good summary, and I don't need to talk about it anymore. If you want to read those slides, go for it. Again, it's not testable. Other than that one question, that's it. So, final thoughts. Thank you guys so much for being a great class this year. This is my 5th year doing this, so I'm made changes every year, so I really thank you guys for all the improvements. I'll just give you guys a little bit of information. I'm changing the class a little bit next year, so it's going to be more of a flipped classroom. I'm going to be doing a little bit more online, by and large. Not all online. It's still going to be about 50-50 is what it's going to be in the fall. So so the feedback for those types of improvements in technology and recordings and stuff like that has been really beneficial for me. So I thank you guys for that. And then feedback's great. I don't get a lot of feedback from people, so I like to say, as you know, the old saying goes, no news is good news. So on rotations, every once in a while I get a question, which is fine. Definitely, if you get a question, email me. But I don't get a lot of feedback on the content. So if you are on rotations, like, oh, we never talked about this, maybe just shoot me an email and I can see if it's worth incorporating or something like that. Your exam passing rates are excellent. They're 100%, so I assume that I'm doing something right there and you guys are learning enough about drugs to pass, or at least you're cramming in enough from your drug study guide that gives you the information there. So anyway, hopefully that's working out, etc. So anyway, feedback's good. I do a fall lecture that's like an antibiotic review with the class every year that just went in onto rotation. So I'll see you guys in a couple months doing that. So anyway, other than that, thank you guys. Have a great summer, rest of the summer, and have a great set of rotations. And it's been a pleasure.